Bismillahirrahmanirrahim. In continuation of our previous discussion on general anesthesia, today inshallah we will be talking about neuromuscular blockers. So the first question that arises in our mind, that why do we need muscle relaxants for general anesthesia? So basically what happens when you are using general anesthetic, you have to intubate the trachea. But if you achieve this facilitation only with the general anesthetic, you will need much more dose of anesthetic. So naturally, if you will use much more doses of general anesthetic, that may result into various complications. So to reduce the dose of general anesthetic, you can use muscle relaxant that will aid in tracheal intubation. Other thing is that it also optimizes the surgical working condition. For example, if you have to perform any surgery in the abdomen, so you need relaxed abdominal wall muscles so that you can easily perform the surgery. So before we talk about the neuromuscular blockers, first we will be talking about the normal neuromuscular transmission. So what happens when a nerve action potential it reaches at the terminal, it depolarizes its terminal, and influx of calcium ion through voltage gated calcium channels into the nerve cytoplasm allows storage vesicles to fuse with the terminal plasma membrane and release their contents. And what is that content? That is acetylcholine. So the acetylcholine molecule diffuses across the synaptic cleft to bind with the nicotinic cholinergic receptors on the motor end plate. This acetylcholine is rapidly hydrolyzed by the enzyme acetylcholinesterase. This enzyme is embedded into the motor end plate immediately adjacent to the acetylcholine receptors. So here basically usually there are calcium channels. So as soon as the action potential reaches, what happens? The calcium influxes through these channels into the nerve terminal, and because of that, these vesicles they fuse with the nerve terminal and the acetylcholine is released, and this acetylcholine then binds with the receptors. That results into the depolarization. And how this depolarization occurs, you know very well, that sodium gets influxed into the muscle cell of the muscle cells, and then potassium comes out, so that creates the action potential. Now about the neuromuscular blockers. Neuromuscular blocking agents basically are divided into two classes, the depolarizing type and the non-depolarizing type. This division reflects distinct differences in the mechanism of action and reversal of blockage. Okay, so actually here you can see that this is basically the acetylcholine molecule, and this is succinylcholine. Succinylcholine is also called as the succinylmethonium. So succinylcholine, it is actually a depolarizing neuromuscular blocking agent. And how it works? Actually, it produces sustained opening of the nicotinic cholinergic receptor channel, so that what happens when it is binding here, it does not allow the acetylcholine to get bind with these receptors. And what it causes? It causes the action potential to be generated. But the problem is that here the action potential is too prolonged. Okay, when it is too prolonged, what happens? So naturally there is no new action potential. When there is no new action potential, the muscle gets temporarily paralyzed. Succinylcholine is not metabolized by the acetylcholinesterase. Rather, it diffuses away from the neuromuscular junction and is hydrolyzed in the plasma and liver by pseudocholinesterase. Succinylcholine has rapid onset of action, usually 30 to 60 seconds, and short duration of action, that is typically less than 10 minutes. Okay. Now, what about the mechanism of action of non-depolarizing neuromuscular blocker? The non-depolarizing muscle relaxants, they bind acetylcholine receptor but are incapable of inducing the conformational change necessary for ion channel opening. Because what happens then, acetylcholine is prevented from binding to its receptor, so no ion plate potential develops. Thus, depolarizing muscle relaxants act as acetylcholine receptor agonist, while the non-depolarizing muscle relaxant, they function as competitive antagonist, because here you can see, for example, the rocuronium. So when this gets bind to the acetylcholine receptor, what it causes? It does not cause any change here, in contrast to the depolarizing type. In depolarizing type, what happens? There is depolarization, but this depolarization is quite prolonged. So no new action potential is generated and then muscle is paralyzed temporarily. But here what happens? The non-depolarizing type of muscle relaxant that gets bind to the acetylcholine receptor, it does not cause any change in the receptor, but what happens? It is actually not allowing acetylcholine to bind to its receptor. That's why there is no action potential generated. And this difference in the action potential that is reflected here. You can see that in non-depolarizing type of muscle relaxant, there is flaccid paralysis, while in depolarizing type, initially there are fasciculations. Why? Because there is generation of action potential and then there is flaccid paralysis. Now the neostigmine is basically the reversal of the competitive or the non-depolarizing type of muscle relaxant. We will talk about later about the neostigmine. So we will talk about depolarizing agent, succinylcholine. Succinylcholine is another name for the succinylcholine. It has quick onset and short duration, as we have already discussed. But what about the adverse effect? For adverse effect, this is very prominent adverse effect, hyperkalemia. And not only hyperkalemia, but joints and muscle pains, anaphylaxis, and malignant hyperthermia. So what happens that under normal conditions, post-junctional membrane depolarization results in leakage of potassium that produces an increase of approximately 0.5 to 1 milliequivalent per liter in the serum potassium concentration. Okay. So when succinylcholine depolarizes muscle that has been depolarized or denervated by maybe upper motor neuron lesion or any other lesion we will discuss in another slide. So enough potassium may leak from the cells to produce systemic hyperkalemia and cardiac arrest. This susceptibility to hyperkalemia is thought to be caused by proliferation of junctional and extrajunctional cholinergic receptors. So patient population at risk for succinylcholine induced hyperkalemia, you can see here that this is the patient population that is susceptible for the hyperkalemia. And remember that this hyperkalemia is really refractory to the normal or routine cardiopulmonary resuscitation. That is the problem. And this risk of hyperkalemia appears to peak approximately 7 to 10 days after this type of injury. Now, what about the malignant hyperthermia? Malignant hyperthermia basically that is not only caused by the succinylcholine, but that may also be caused by the halogenated anesthetics. In this, there is a rise in the core body temperature approximately 1 degree centigrade every 5 minutes, and that may appear intraoperatively or even after surgery, approximately 1 hour after the surgery. So and why it happens? Because in this condition actually there is too much influx of the calcium into the skeletal muscle, and that's why the skeletal muscle, they got rigid. And in this so there is temperature rise and rigidity of the muscle, and that's why we have to give some relaxant. For example, dantrolene is direct skeletal muscle relaxant. So if we give dantrolene, so the effects are reversed, but naturally we have to stop the anesthetic that is causing this issue as well. Okay, with the exception of the mivacurine or non-depolarizing agents are not metabolized by either acetylcholinesterase or pseudocholinesterase. So their effects are reversed by cholinesterase inhibitors. Okay, because you see, for succinylcholine we don't need any reversal agent, because its effect is of short duration and it is metabolized by pseudocholinesterase. Okay, but here in these agents, non-depolarizing agents, we need reversal by cholinesterase inhibitors, for example neostigmine. So what happens with the neostigmine? Neostigmine actually inhibits the acetylcholinesterase enzyme activity. Because of this inhibition, there is increase in the amount of acetylcholine that is available at the neuromuscular junction, and this now can compete with the non-depolarizing agent and the effects are reversed. Okay, neostigmine along with other anticholinesterase inhibitors can stimulate the muscarinic receptors in the airway smooth muscle, which can lead to the bronchospasm. So now whenever we are using neostigmine, we have to attenuate these adverse effects by concurrent administration of an anticholinergic agent like atropine or neopyrrolate or glycopyrrolate basically. So glycopyrrolate, here you can see neopyrrolate. In this neopyrrolate you can see glycopyrrolate is combined with the neostigmine. So why glycopyrrolate? Because this is anticholinesterase. This will attenuate the effects of neostigmine that may result in the bronchospasm. So because of this glycopyrrolate, bronchospasm is reversed. Previously atropine has also been used, but now usually atropine is not being used. Neopyrrolate, it is the one that is used. Now there is another reversing agent, that is sugammadex. Okay, what happens with the sugammadex? Actually, sugammadex exerts its reversal effect by forming tight complexes with non-depolarizing agents. Okay, here you can see, and these agents, for example, the vecuronium or rocuronium. Here you can see that this is the rocuronium, while this is the molecule of the sugammadex. So this actually attaches with this, and when it makes a complex with this rocuronium, what happens? So naturally this is not available to function at the acetylcholine receptor. Because of that, effects are reversed. So what about recovery? As you remember that we discussed in our previous discussion that there are three main phases of general anesthesia: the induction phase, maintenance phase, and the recovery phase. So in the induction phase, we give usually the IV anesthetics, although we can use the inhalational agent as well for the induction, but not used as routine. So IV anesthetic for induction. Along with that, at the induction phase, we are also giving analgesia, and along with the analgesia, we are also giving at the same time muscle relaxant. Okay, so when we have to reverse the effects of general anesthesia, simply we have to stop the anesthetic, whatever type of anesthetic we are using for the maintenance phase. So we have to stop it. Now what about the reversing the effects of muscle relaxant? So for succinylcholine, that is the depolarizing type, since it is automatically hydrolyzed by the pseudocholinesterase, we don't need any other reversing agent. Rather, just stop giving the muscle relaxant, then the effects will be reversed. But if you have used a non-depolarizing type of muscle relaxant, so in that case you have to give reversal, as we have discussed in the previous slides. So this is my reference book. Thank you very much.